I'd like to discuss a technique that I developed that is exactly the opposite. It is allowing active motion to drive passive motion. This technique is called casting motion to mobilize stiffness, or the acronym would be CMMS. This started many years ago with this patient who had the active finger flexion seen on your left and the passive seen on your right. She had had a distal radius fracture 9 months earlier. After 3 days of casting, she returned and had this active finger flexion, which we had been unable to obtain during the entire 9 months. So I would suggest to you this quote from Edwin Land. It's not necessarily that we need new ideas, but we need to stop having old ideas. What are the old ideas I would throw away? Passive motion before active motion is not required. We also believe we should never immobilize the MP joint in extension. There are times, in my opinion, when that is very appropriate to get the mobilization that we need of the IP joints and to elongate the interosseous and or lumbrical muscles. Never lose motion in one direction to gain another. I feel like in the chronically stiff hand, sometimes that's actually very necessary. And never immobilize any part of a stiff hand. I believe that immobilizing the looser joints and driving motion to the stiffer joints until the resistance is equal is a technique that will allow a patient to retrieve a normal balance of motion. It will very quickly shift them out of the maladaptive pattern. The CMMS technique uses cyclical active motion to mobilize stiff joints. There's no previous model of this. This is not presented as a treatment approach. Cyclical active motion, constrained and directed so that it's occurring within the range and at the joints that most need it. It uses plaster of Paris casting. Plaster of Paris because it's a more intimate mold, which is the important element for reducing chronic edema. It selectively immobilizes proximal joints to direct distal joint motion. Sometimes you can control a more proximal joint, but the more usual is distal joint motion. What other treatment do you know that could direct motion, for example, to the PIP joint for both flexion and extension equally? Most of us are really frustrated because we focus on extension, lose flexion, and vice versa. This chart illustrates one joint of one finger that underwent the CMMS technique. It covers a period of 1 year, and it starts at a point where the active, illustrated by the red, and the passive, illustrated by the yellow, are almost equal on the first visit. The patient undergoes the treatment technique, and for reasons I will explain later, the range of motion is reduced initially and then is gained. But the most important thing to take away from this chart is to look at the red and look at the yellow and realize that the yellow always is greater than the red. The passive is always greater than the active. And yet, the only treatment technique ever used was active motion, no passive motion. So this proves that passive motion can be driven by active motion if it is redirected to the stiffer joint. So the CMMS technique is intended for chronic stiffness because, as we discussed earlier, there are 3 elements that are interrelated, and changing only a part of one element will not affect change in the other 2. The CMMS technique reduces the chronic edema because the patient is actively pumping inside the cast. Joint stiffness and tissue adherence is diminished because the active motion is driven to the joints with the most resistance. The patient is unable to recreate the maladaptive pattern, and because of that, it reduces the stiffness, but repeating the new pattern within the cast repatterns the motor cortex. This happens simultaneously and can break through this chronic, frustrating pattern of stiffness. Here is an example of active motion mobilizing stiffness. On the top left photograph is a picture of active flexion the day the cast is applied. The patient had had a laceration of all flexor tendons and the median and ulnar nerve, thus the reason for blocking the MP joints and some flexion. This active motion was able to gain the mechanical mobilization of the stiff joints and the tendon glide, while simultaneously repatterning the motor cortex with repeated motion and stimulating the lymphatics to pump the chronic edema. So active motion does mobilize stiff joints. It does it by repeated, gentle, prolonged direction of force to the stiff joint, and because the cast is initially removable, it means that the patient cannot repeat the maladaptive pattern. It is important that it's non-removable in the chronically stiff hand because repeating the maladaptive pattern will reverse what you have accomplished by creating a new pattern. The goal is to not revisit the maladaptive pattern and to slowly wean out of the cast. Active motion repatterns the cortex. The experience of moving correctly allows the patient to begin finger flexion and to glide the tendons to their maximum for full finger flexion. And the pumping of the stagnant lymphatic system is achieved by distal motion, gentle, firm, sustained pressure proximally, and the active motion is intermittent and therefore serves as a pumping mechanism. Now let's continue to look at the CMMS technique and focus a little bit on the mechanical and then the cortical. In looking at this technique and developing it, I came across an article in 1995 by Arbuckle and McGrather, where they had placed sensors on fingers of normal subjects and had a computerized image of motion. When they compiled this together among, I think, 11 subjects, they were able to offer this schematic of normal digital flexion. These dots would represent the wrist, metacarpophalangeal joint, PIP joint, and DIP joint. So the patient would start from extension, initiate flexion with the IP joints, and go into a rather significant hook posture prior to significant MP joint flexion. The latter part of flexion focuses then primarily on the MP joint. Insight into this normal pattern really helped me to realize that one of our goals when approaching a patient with a stiff hand is to help them recreate this pattern. In other words, interphalangeal joint flexion occurs prior to the majority of MP joint flexion. Because we have been taught that the MP joint must always be flexed because of the collateral ligament, often we start by mobilizing the MP joint. And to me, that reinforces a maladaptive pattern. In this patient, you can see that the fingers are nowhere near the hook posture. There's relatively more MP flexion, and there's no wrist extension. So there are a number of elements missing when you watch this patient move that you want to slowly help the patient recapture. Here again is a chart illustrating the effect of the CMMS treatment technique. In this case, we're illustrating all of the fingers, and you'll notice that it is also a chart that covers a span of 1 year. This is important because the primary treatment period was up to 18 weeks, but when we get to 50 weeks, we notice the significant improvement from 18 forward. If we look at this initial period, which is only 3 weeks, you will notice that there is a decrease in active metacarpal phalangeal joint flexion. This is absolutely to be expected because we are endeavoring to help the patient initiate with IP joint flexion, and that means we're blocking the MP joints in some extension. The next period of 5 weeks, we see then an improvement in MP joint flexion. Remember, this is only the MP joint we're looking at, and there would be another chart that would chart improvement in interphalangeal joint flexion. But you will note at the period of 8 weeks, we are not yet back to the pre-treatment levels. This would be of major concern to many people. But the chart showing the interphalangeal joint flexion has increased. We then discontinue the cast on a weaning basis, and over a long period of time, the patient returns back to the normal range of motion. Treating chronic stiffness requires a different mindset, a different approach, and a great deal of patience and a longer period of time. It is simply joint blocking. Instead of allowing limited IP joint flexion and significant MP flexion, we are directing the force to the stiffer joints for a period of time until the resistance is equal and the brain is accustomed to initiating motion differently. You may recall me saying that most of us believe we should never lose motion in one direction to gain in another. I now think about that differently. Here we have the suggestions of a balance between flexion and extension. And normal balanced motion would have those relatively equal in their ability. But let's say there's a maladapted pattern where there's an extension contracture. In other words, limited flexion. So the flexion has less of an accent and the extension is a heavier weight. In order to recreate the balance, we have to take the maladapted pattern and actually put it in an opposite balance. We have to over-accentuate flexion for a period of time so that it then has an equal representation to extension in the motor cortex, as well as the muscles themselves in terms of their strength and their ability to spontaneously initiate. This does, in my experience, require gaining motion in one direction while temporarily losing it in another direction. It takes faith that this will rebalance over time, as seen by the previous chart. What about the cortical response to this CMMS technique? The good news is that once a new or novel motor task is learned, the functional topography of the brain stays altered for a long period of time. That means two things. That means that because we are returning the patient to their normal previous range of motion, that they can easily revisit that, and also that periods of constraint within the cast are significantly effective for a longer term. But for repatterning to occur, the motion has to be repeated over time for it to be effective. Short periods of exercise are not very effective in changing the stiffness in the chronically stiff hand. For repatterning to be successful, it requires conscious attention. I ask the patient to look at, think about, and even move the other hand simultaneously as they're working to regain motion within the CMMS cast. You must place the fingers in the position that allows them to reactivate previous representations, and you must allow the cast to stay on for enough repetitions over a long enough period of time to truly affect a long-term change. We know that repetitive passive motion, if you don't think about it and concentrate on it, provides almost no changes. Focused attention during the motion is required. It is a key piece to being successful with this technique. The CMMS technique can dramatically change the quality of the tissues in the hand by facilitating lymphatic flow. If there's limited active motion, there is a restriction of the normal lymphatic pumping. There are no muscles within the fingers, and therefore, muscle contraction, unless it results in interphalangeal joint motion, does not facilitate lymphatic flow within the fingers. There may or may not be some injury to the lymphatic system, but regardless of whether there is direct injury to the lymphatic system or it has become stagnant and is unactivated, the CMMS technique can facilitate lymphatic flow within the distal part of the hand and fingers. We know that once edema is present, there is increased resistance to lymphatic flow, which then only serves to increase edema and long-term to create fibrosis by the accumulation of this high protein edema that cannot flow away from the injured area. So there are 4 ways in which the lymphatic system is stimulated by the CMMS technique. Most of all, active motion, somewhat by consistent light pressure, constant, warmth, and a light massage or pressure, which I call a pseudo massage. We all know that the single most effective stimulator of lymphatic flow is active motion, active pumping, active muscle contraction, active joint movement. It increases lymphatic flow from 10 to 30 times, but if you are immobile, it is sluggish lymphatic flow. The lymphatic system has no primary pump other than motion. The cast provides a consistent, well-contoured, non-constrictive light pressure that does not crush the thin and weak lymphatic vessels. It's like putting a cast around an egg. You want to support it, keep it warm, but not crush it. The well-contoured mold on the palmar aspect of the hand provides well-distributed pressure, and each time the patient flexes and extends, there is cyclical pumping of the lymphatic system. Warmth is accomplished by the insulating quality of the cast, which provides neutral warmth. It has been demonstrated that there is a direct relationship between the ambient temperature and the increased permeability of the initial lymphatics, knowing, of course, that excessive temperature would overwhelm the system and would thus provide a negative response. The neutral warmth then appears to be an appropriate level to maintain a temperature that also facilitates lymphatic flow. Those who have been taught techniques of lymphatic drainage have often described it as lightly petting a cat. The CMMS technique creates a pseudo massage where the initial lymphatics that are in the skin get very minimal pressure, which is the pressure level they can tolerate, from the movement within the cast, from the sustained external compression, and also just from increased arterial pumping as a result of active motion. In other words, the stimulation to the lymphatics occurs each time the patient moves the fingers. And this is consistent throughout the day. There are not periods of stimulation and periods of absent stimuli. It is known that gentle compression and then relaxation is best. Therefore, the cyclical active motion of compression with flexion, relaxation with extension, greatly facilitates the lymphatic flow.